respected chairs, and Gigi sir for inviting me here. Greetings from the World Headache Society and Narayana Health. I founded the World Left. I'm director of the WHS Academy, and we have 450 students from around the world doing our one-year distance learning fellowship in head, neck, and face pains. I am the chief associate editor of Headache Medicine Connections, the official journal of WHS. At this point, I'm a reminder of Sri Balendra Menon, who used to be known as Katha, Tirakatha, Sambhashanam, Sangeetham, Rajana, all in one. But I also want to note that we have a very large number of stalwarts in our team. It is really an honor to present before my teacher, Professor Suresh Kumar sir. Recently, Dr. Reddy's, who markets Iranumab in India, came to me saying that Suresh sir said that I am the only clinical fellowship trained and certified headache specialist in India. I'm not surprised considering how large-hearted he is. I currently direct the headache program across 32 hospitals of the Narayana Group in India and Cayman Islands. These are my. It is quite as important to know what kind of a patient the disease has got as to know what sort of a disease the patient has got. When I passed out of medical school with a gold medal, my first posting in PHC, a patient came. I remember the lady. She had a prescription of amitriptyline in a prescription, and she had headaches. Then I asked, why do you need amitriptyline for your headaches? And she said it was prescribed by a GP. I said what I wanted to talk about today. And we have all been in the area, gone through this, and there are many news in headache medicine. Now, what is a paradigm? A paradigm is a model and a pattern, and historically patterns change with new information. First, what is the range of headache medicine? We will first see that. And then, what are the fallacies in the definitions, and what is the role of a syndromic classification? Third, we look at Yudhishthira's lie about Ashwatthama and how it is linked to today's talk. Fourthly, we will re-examine whether our history taking needs updates. Then we will see if our headache examination needs updates. Lastly, we'll see how this is applied in our treatments. A physician is traditionally a good diagnostician. A headache specialist should be able to diagnose all the causes of pains affecting the head, which includes the anterior and posterior neck and the face, including the eyes and the ears, especially when referred by another specialist, say ENT or ophthalmology, when there is a diagnostic dilemma, and also to guide the headache specialist to refer to another appropriate specialty. Along with the Sherlock Holmes level gratification behavior neurologists are so used to, we have moved to interventions in all our neurological subspecialties. A neurosurgeon once told me that we are operating neurologists. I also wish to say at this point that a neurologist should also be a non-operating neurosurgeon, at least from the approach point of view. We have been using research criteria in the last few decades. We know the drawbacks. We know that diseases are biological, but also that diseases are contextual and cultural. A patient will see an ophthalmologist for a blurry vision and migraine, and the headaches improve with correction of refractory error, or it could be a placebo effect. Whilst the biology involves the thalamus and the sensory cortex, and also the neuroscience of placebos, the knowledge gap in both clinicians and patients can make diseases contextual, cultural, or what we call as the norm. Second, definitions change with better understanding of the disease and is not etched in stone for the next 10 years, because we rely on a few people to publish it somewhere and from there to penetrate our medical textbooks. Headache medicine has followed research criteria over the years, therefore missing outliers and the extended spectrum of many headache disorders. Lastly, the foundation stone of a neurologist is that of a syndromic approach. I created the World Headache Society Multi-Axial Classification of Headache Disorders, Edition 1, with which you as a neurologist or your nurse as your assistant will be able to diagnose any headache disorder. Talking about nurses, in the UK there are headache nurses to whom neurologists refer for complex headaches. So which means that headache is something which you might see in a country like ours, where even an Anganwadi worker or an ASHA worker would also be one of the first line. If you're talking about villages, one of our country chapters of the WHS in Sierra Leone, there are community health workers who treat headaches. So that being the case, how do we evolve a clinical tool classification system which can be used by everyone alike and not just research professionals? The first axis of this classification involves a 1-hour training for any any healthcare worker who sees headaches. My professor, my teacher, Professor Anand Kumar, always used to ask us residents, what is a syndrome? A syndrome is a cluster of symptoms and signs due to more than one cause. Throughout neurology, we are approaching any neurological condition as a syndrome. Right? We have traditionally followed this syndromic approach, and in all of neurology, but we are following a research definition-based criteria for headache disorders. And following this, you can place any headaches in one of these categories. Every axis of 1 can be linked to axis 2, which means that suppose a nursing assistant is to see a patient and you are teaching the patient, teaching the person how to then direct this patient to the other syndrome. So you can see that the axis 1 is connected to axis 2. It's relatively simple. One of the other, I would say, one of the misplaced understanding of tension type headaches. Now we know that they are mini migraines, and this is very much evident in even now, although that many people won't admit. Throughout the world, headache specialists now understand this, and they would say that they are just almost the same. Even in the criteria, you can see there are so many overlaps. And important thing is, when it comes to the CGRP receptor antibody studies and research, the headache days means the tension type headache days, and the migraine days means the migraine, the full-fledged migraines. Now this Ashwadhama Hada Kunjaraha Avyakta is what I wanted to just specify. That certain areas are part truths and some areas are grey zones. A classification that has taught us to classify headaches phenotypically, like airplane headaches, nummular headaches, epicrania fugax, should move towards a mechanistic, epicenter, and neural circuitry based classification, which are again based on syndromic classifications like those given in WHS MCH1. So airplane headaches become barometric environment related headaches, and nummular headaches become neuralgias. The fallacy of classifying as primary and secondary headaches is another one big thing which is kind of held sway for the last 30 years. It's not very easy to undo it. So what we should now understand is that a migrainous symptom is nothing but the end of stream phenomenon of many headaches, and it just means there is a dysregulation of sensory processing, focal brain dysfunction, or sensitized nerves of the trigeminal or the other cranial nerves. It's an end of stream phenomenon. Now, all headaches, I'm not sure the person who was asking me yesterday when I gave that fellowship introduction, it's about what is the point in just periphery, in dealing with the periphery when we have to focus on the central problem. See, all headaches, you can say that it is either the manifestation of pain is because of the trigeminal nerve and its branches can be the 7th, 8th, 9th or 10th. There is an abnormal sensory perception involving the thalamus. And there are abnormal neural systems involving the cognitive, subcortical, brainstem and connections. And then there is sensitization involving hyperalgesia, allodynia. We know all this. So the important aspect of clinical examination, the lost paradise of surgical approach in medical training is that traditionally, we as neurologists, we start with the higher mental function examination, go to cranial nerves, then motor system, sensory system. We forgot what exactly our Das textbook of surgery, which we did in MBBS, where we actually had to examine a head and neck in such thoroughness, involving every part of the oral cavity and the face, and then diagnose structurally, and then finally go on to identify the epicenter, sensitized areas of the face and neck, to see whether it's a neuropathy or whether it's a muscle involvement, and examine the oral cavity. So it's a movement from being just a needle jockey to that of a neuromodulationist. The focus should be on vascular anomalies and migraine and stroke connections, autonomic manifestations, hypotension, tachycardia, dizziness, oralis visual symptoms like entoptic phenomena and diplopia, attention, memory, praxis, language and behavior. It's important to have an epicenter-based diagnosis in many of these conditions. This patient came with a history of very severe migraines and psychotic behaviors. She used to be seeing apparitions, ghosts, people, and she also had a very interesting phenomenon that she could see the future. This is what the fMRI actually showed. It's important to, as a neurologist, to go to the root problem and where exactly can we localize all these hallucinations. History taking also the importance of EMRs and registries and how we are able to then create that large database and bringing syndromes in history. And then as far as the treatment updates are concerned, this is something which we all know now: focused blind and ultrasound guided nerve blocks, branch blocks, ganglion blocks, botulinum toxin, CGRP monoclonals, GPANs, yoga and nutraceuticals. Another important thing is what is called as the IV infusion protocols for people in critical care with severe headaches. You can treat them with many of these infusion protocols and also with sphenocath, which is a topical sphenocath, palate and ganglion block. So this is a patient who actually came with a suspicion of an Eagle syndrome, a glossopharyngeal neuralgia or a TMD. And it's important, the orofacial pain specialist had done a Botox into one of the muscles of the face, and along with that there was also a glossopharyngeal nerve block was done, but unfortunately the patient did not improve. So what is more important is to go through the examination once, identify which are the sensitized areas, and then give multiple blocks. For example, in this patient there was a mental block given and also supraorbital, as well as identifying what we are seeing in the middle is the stylohyoid and giving it in the region of the stylomastoid. Now this is a patient who came with an MRI and MR venogram from Jharkhand, and this patient had, she just came for a second opinion. The patient had a small Fox calcification, but eventually on clinical examination there was a mild asymmetry on sensations in the face, found to be an aneurysm, and flow diverter stent was put, and after that the patient improved. But subsequently the patient continued to have a headache. The patient said, "Why did you do a procedure for me?" So it's important to understand the migrainous symptoms persisting even after aneurysms, because the end stream activation has been done. Unless we treat that, there's no point and there's no improvement. So for certain conditions, the lady on the left that you see is a person who has got a V1 herpes zoster ophthalmicus 21 days into the illness, who had very severe pain that she wanted to kill herself. and another one with a refractory trigeminal neuralgia. Some, in history taking, it's very important to know some of these facial deviations need not always be a stroke, can be part of a migraine syndrome. The extended spectrum of migraine syndromes involving focal dysfunctions of any part, and always go into focused neurological examinations. There are so many nerves which can be neuromodulated. Calling them blocks is probably one of those terms which has been derogatory we have always looked upon neurologists thinking that the anesthesiologists were doing things, but they were actually neuromodulating. With one single block, many of these patients have had very long-term improvement. And the importance for advocacy at a central level, unless the patients are educated, none of what we do will make sense. We have to decentralize headaches right to the lowest levels. At a complex headache service, what we normally do is we have device treatments for migraines and cluster headaches, supraorbital and supratrochlear stimulation devices, non-invasive vagal stimulation, combined multi-channel stimulations, remote electrical neuromodulation, transcranial magnetic stimulations, and also transcranial direct current stimulation, infusion therapies, and intracranial pressure monitoring and adjustments for intracranial hypotensions, and other non-pharmacological therapies, yoga and mindfulness video modules. And as a society, we have now 110 countries, and this is the axis 345 of WHMC1, giving importance to the patient's narrative. We always focused on diagnosis, that we forget what is the most important troublesome problem of the patient. Document that, try to find a biomarker, which can be imaging, genetic study, biopsy, and find out what is the impairment scale at every single visit. And lastly, I just want to mention about the first ever headache fellowship program in India, which we are offering as a 2-year hybrid program, of which 1.5 years will be distance, 6 months would be at Bangalore. And we have a center, a comprehensive center, which is exclusively devoted to headache disorders. Thank you, ladies and gentlemen, for your patient hearing.